Alright, so it's been a while since I've done any of these NBME explanations. This one is for NBME 22. So what happened was, as I was putting together these NBME explanations, it started taking a toll on me because it's actually a lot of work. But I did realize that it's an excellent form of studying. Like, I got to learn so much more, and I became so much more proficient at so many topics as I was going through all of this. Um, you read questions, you look at all the answer choices, you pick the right answer, and then you check what the correct answer is. And depending on the type of form you downloaded, it might tell you what the correct answer is, or you can check online. There are many websites that have the correct answers on it. And then you go ahead and go through first aid, right, and gather the explanation, like a UWorld type explanation for the correct answer. So that effort of doing that kind of work was actually really beneficial, because the more I did it, the more I realized that it seems like an excellent way to study for step one had I been preparing for step one right now. So that's one really critical thing. And then the other thing was that I still needed to finish up first aid, and with the holiday seasons coming in, I was like off for almost a week right there too. But it was a fun Thanksgiving. It was a fun time just meeting friends, eating food, hanging out, and then of course shopping, which still isn't over because today's Cyber Monday. So after this streaming session, I'm gonna go ahead and check if there are any good sales online for some of the things I want. But yeah, so definitely a very helpful way to study if you are preparing. Now, one additional thing I'm going to be doing this time around when I'm doing NBME 22, usually when I do NBME explanations, I'll read the question, I'll tell you the explanation, I'll try to explain how the wrong answers are wrong and how you could figure that out, and then I show you the connection from first aid. That's what the page numbers here are about. The new thing I'm going to do this time, though, is I'm also going to start making a list of what was on each question, right? So I'm going to put a little topic page on my other screen over here, and on that page, I'm going to write down every single, like for this question is about avascular necrosis, so I'm going to write down number 1, avascular necrosis, on my other screen over here. What that's going to help with is that at the end of this, I'm going to add it on the last page, so you can see, what topics are questioned on NBME exams, because NBME has a smaller scope of questions, than Step 1 does. Step 1 is pretty much everything that's in first aid, plus even more, right? There are even things that are not in first aid that will be on Step 1. Whereas NBME is almost like, I would say about 60% of first aid, plus a few tiny topics that are completely ridiculous and won't be in first aid, right? But not something realistic. So I'm gonna start compiling a list of topics that are frequently and commonly present on NBME, because those are the topics you need to master in case your school requires you to take NBME, right? Because then for you, if NBME is required before step 1 by your school, then NBME is a very realistic exam for you, whereas many other people take NBME just because it helps them gauge how well they're prepared. Okay, let's see. So that's one thing. Okay, so now we can go ahead and get started. So this is block 1. I'm going to do all of block 1 right now. Actually, not all of it. When I do NBME explanations, I do them in sets of 25 questions at a time. So I'm going to do the first 25 questions of block 1 right now. Alright, so right here, the first question, 49-year-old man comes to the physician because of increasingly severe pain in his left hip during the past 2 months. He was recently discharged from a rehab facility for treatment of alcoholism. He says the pain gets so bad at times that it even hurts my golf game. He has he has pain with weight bearing. Physical exam shows limited active and passive range of motion of the left hip. Hip x-rays show no abnormalities. A coronal T1 weighted MRI is shown. Which of the following is the most likely cause of the patient's pain? So you can look at the two hip girdles right here, and this is the left one, right? Because you're looking at the patient looking at you. So this is the left one, this is the right one, and there is a tiny difference between the two, and that tiny noticeable and significant difference is the presence of this thing right here. Right? You see that gray line? There's no gray line here, right? There's no line like that over here. So something's definitely wrong on the left one. Now you look at your answer choices. Avascular necrosis definitely fits. As soon as you read it, you're like, yeah, it could definitely be avascular necrosis. Hyperparathyroidism doesn't really fit, doesn't necessarily make sense. Osteitis deformans doesn't make sense. Septic arthritis is another possibility. And then tuberculous osteomyelitis doesn't fit either. So this is a link right here. I'm going to put it into the chat. That kind of shows you more images, very similar to the one given in this question. It shows you normal ones as well as more other pathological ones. MRI is highly sensitive, specific, and accurate in the detection of avascular necrosis. T1 weighted images. Avascular necrosis most often presents with a crescentic, ring-like, or well-defined band of low signal within the superior portion of the subchondral femoral head bone marrow. And that's what you're seeing there, at the superior portion of that bone marrow. This band is thought to represent the reactive interface between the necrotic and reparative zones, and typically extends to the subchondral plate. Remember that this is insufficiency of the medial circumflex artery, which is definitely a high yield topic. You'll also have the lateral circumflex artery as an answer choice. Don't pick that one. And another giveaway in this question was the alcoholism. Right? Alcohol abuse is a risk factor for avascular necrosis, and he is an ex-alcoholic. So the page numbers that I have over here are for my personal first aid. So when I go to the first aid, you can definitely see what the actual page number is for the hard copy, if that's what you're using. So page 505 for me. Let's take a look. Right, so this is page 453, right, and that's the other number that I put here. 453 is the actual page number of first aid. So right here you see this Legg-Calvé-Perthes disease. Right, this is idiopathic avascular necrosis of the femoral head, which commonly presents between 5 to 7 years of age with insidious onset of hip pain. Right, this is the idiopathic, sorry, not age, 5 to 7 years with insidious onset of hip pain that may cause the child to limp. Right, so that is the age. So the Legg-Calvé-Perthes disease is something that very few people tend to remember, but that's actually just idiopathic avascular necrosis that occurred for no real reason whatsoever, and that occurs in really young kids, right, as you can see in this explanation here. But then later on, they also mention the actual avascular necrosis of bone, this one right here, right, and this is on page 455. And they tell you it's infarction of bone and marrow, usually very painful, like our patient. Most common site is the femoral head watershed zone, which is pretty much what they're pointing out with these red arrows, due to insufficiency of the medial circumflex femoral artery. Right, so you can see the medial femoral circumflex artery comes from behind. Right, the lateral one is in the front. Causes include all of these things, and our patient had the alcoholism. Right, but the other things are corticosteroids, sickle cell disease, trauma, lupus, bends being like caisson decompression disease. If you don't know what those are, you definitely want to Google them. I've talked about them when we did this video of musculoskeletal. Legg-Calvé-Perthes disease in kids, Gaucher disease, and then the slipped capital femoral epiphysis, which is where this basically slips out, and they call it the ice cream cone X-ray, something like that. So those are all the different ways you can have avascular necrosis. Now, very simple anatomical topic, but definitely very high yield, right? This one right here is showing you the slipped capital femoral epiphysis. This is another thing that occurs in really young kids, mainly very obese young kids. The acetabulum looks like the scoop of ice cream that came out of the cone. Right? So that's kind of how they often tend to describe it. And you can fix it, you can definitely fix it, but it's still very painful and problematic, and definitely not something you want your kids to go through. All right. So that's one right there. So let me go ahead and add that into my list. Number 1, avascular necrosis. All right, 2. So number 2 now is another pretty much anatomical question. So this one says, a 16-year-old girl has pain and tingling in her left hand when she goes backpacking. The symptoms resolve 5 minutes after she takes off her backpack. Which of the following abnormalities is the most likely cause? Right, very unorthodox way to present this topic. And that's kind of what UWorld does. They'll present topics in a way, sorry, not UWorld, NBME does. They'll present topics in a way that is not really something students might be accustomed to, and that's very realistic, right? Because most of us are now used to seeing topics in a certain way. We're used to being given topic scenarios in a very specific manner, such that we label it as a pathognomonic thing. That hey, if a patient presents with X, Y, and Z, they definitely have disease A. Right now, NBME presents topics in such a different manner that that little pathognomonic scenario that you were used to is kind of gone. So here, the putting on and taking off the backpack is directly related to pain and tingling in the left hand. Okay, so you look at your answer choices: C7 to T1 congenital fusion, a cervical rib, diastole, matomyelia, whatever that is, hemivertebra, and the spina bifida occulta of C7. So this was a question on thoracic outlet syndrome. Let me add that to the list right now. And here the answer was just B, a cervical rib, like the one given in this UWorld picture right here. So you have to remember everything about thoracic outlet syndrome, because there really isn't too much to remember, but it's very significant and very easy, right? And you can see your brachial plexus stuff right here coming out from between the anterior and middle scalenes, right? And it's kind of being compressed because of this extra cervical rib that isn't really supposed to be there, but can be there. Compression of the lower trunk causes atrophy of the intrinsic hand muscles and may have tingling along the ulnar and median nerves. Stretching, occupational, and physical therapy are common non-invasive approaches used in the treatment of thoracic outlet syndrome. The cervical rib can be surgically removed. Below is a UWorld question on the same topic, and it goes into talking about the scalene muscles and this image above, right? So I added that in too. You could take a look at it on your own time. But basically, what I want to do is I just want to read the explanation, not the explanation, the scenario that the question presented with. So they tell you a 15-year-old boy is brought to the office for the same kind of thing, right arm numbness. He plays baseball and has been practicing his pitching for an upcoming game. For the past many weeks, he has had fluctuating tingling and numbness in the right shoulder, arm, and hand. He also has recently developed dull pain in the right little finger and hand, right? So that's kind of more of the ulnar thing. The symptoms worsen with overhead activities and when throwing a baseball. He has no medical problems other than being told he has an extra rib, which they gave away, right? Basically, the answer of this question, right, our NBME question, the extra cervical rib was the answer. And this UWorld question, they put it in the scenario. On exam, there is decreased sensation over the medial two fingers and hypothyroid eminence of his right hand, which is a giveaway that there's an issue with compression of the lower trunks. What structure is most likely contributing to his condition? So obviously the extra rib is contributing, and that was already given. The other thing that's significant are the scalene muscles, right? So very important to remember, that was the answer here. All right, so definitely a very nice topic, very easy topic, easy to catch. When you're learning your brachial plexus, you want to make sure that you have a very good visual understanding of how it works, right? How the distribution works. This color-coded brachial plexus image here is one of my favorites because it kind of shows you where the injury has to be for symptoms to present on the body, right? So you can see the lower trunk, which is color-coded blue, causes symptoms in the hand, right? Because those guys are the ones that are going to give to median and ulnar nerves, which are for the fingers and whatnot. Everything else is also color-coded as well, and the few palsies and syndromes on this page, there's only 4, are very straightforward, right? When you're first studying the brachial plexus, it's super easy to go over them. Really make sure that you get what's happening, right? Make sure you add in the extra information that's not here. For example, what nerves are being affected, what nerve is related to which muscle, that's being listed out. right? And then understand the actual functionality of the muscle and how the patient is going to present in a scenario. Whether they fell like this guy over here, or whether they were pulled out incorrectly as an infant, right? And there's two different ways to pull out an infant incorrectly. Right? Herb and clumpcake are very different from each other. They're on opposite spectras. Herbs is C5 to C6. That's all the way up here. Whereas clumpcake is C8 to T1. Those are the same ones we've been talking about right now. Alright, so very nice topic, very easy topic. Just want to make sure that you kind of get how to tackle these questions. What I didn't do when I wrote this down, I didn't talk about what this is. So let me actually just Google it real quick. Diastema tomyelia. What a weird name. Is a congenital disorder in which part of the spinal cord is split, usually at the level of the lumbar vertebra. Okay, definitely a very unorthodox topic. Haven't really heard of that before, but I'll throw that in there just in case. Alright, so never heard of that, but you know, it never hurts to know a couple things here and there. Yeah, Dave, go for sure. Dave, Vanessa, anyone else that's watching, if you have questions regarding advice or any kind of confusion you have regarding like how to study and stuff like that, you can always feel free to email me. And if you have questions on anything I'm talking about right here, you know, one of the reasons I do these streams live is so that you can ask questions for sure. So, you know, if I'm doing any question and you have some kind of doubt about whatever I'm talking about, feel free to just ask. And as soon as I'm done explaining this, I'll go ahead and tackle what you were saying. So question number 3 here, a 48-year-old man comes to the physician because of fatigue, increasing shortness of breath, and exertion, and decreased exercise tolerance over the past 4 months. An x-ray of the chest shows cardiac enlargement and prominent pulmonary vasculature. He is treated pharmacologically but subsequently develops glucose intolerance, evidence of liver dysfunction, and mild to moderate ascites. An older brother died at age 52 with similar symptoms. Which of the following are the most important screening tests to perform on this patient and his family? So when you get a question about, you know, liver failure leading to death, which usually means that it wasn't just liver failure, it was probably liver cancer too. You want to think of the few things that are, you know, familial regarding this kind of topic, and hemochromatosis is one of the top ones. So the patient has dilated cardiomyopathy, right, which is the reversible thing that occurs with hemochromatosis, but classically hemochromatosis patients have restricted cardiomyopathy because of all the iron. He also has intrinsic liver failure, which is obvious because of the ascites. Remember, ascites is a giveaway whether it's an intrinsic liver failure or if there's no ascites, then there's something wrong outside the liver. He also has a family history of it because this is autosomal recessive. The most important screening test would be to check for iron levels. There is so much iron that ferritin, transferrin, and iron will all be loaded up, so TIBC will be low, right? Because remember, TIBC is transferrin iron binding capacity. With transferrin will not have any iron binding capacity because all the transferrin will be bound to iron already. Hepatocellular carcinoma is the common cause of death with patients who have hemochromatosis, and here the answer was just E, transferrin saturation and serum ferritin measurements. Very easy question, very straightforward topic. They could have asked this topic in a slightly more confusing manner. So this is hemochromatosis. But, you know, they kept it pretty straightforward. And when you go to page 428 over here, so 389, now you get to see some of these, right? So Wilson disease is another one where you can have liver issues. And then hemochromatosis is the one that our question is about. There's a lot of things involved in hemochromatosis and how it presents and what you can get in your question scenario. UWorld even had a question about a woman who had hemochromatosis, and so did her husband apparently, but the husband had it worse, and it was because the woman was losing iron in menstruation, right? So that's definitely another thing that they talk to you about right here, and you have to make sure you watch out for that. Another thing they do is the presentation. They'll tell you patient presenting with weird pigmentation. They might even just call it a rash, even though it's really just pigmentation, and diabetes, and then some kind of liver issues, and all those, you know, those three things being in the same patient is supposed to be a sign of hemochromatosis. So you really want to make sure that you're able to catch hemochromatosis anytime you see it. The technical things to remember are the HFE gene located on chromosome 6, association with HLA-A3. Alright, so these are like the very technical, silly things to remember that you can get stupid questions on, but not exactly the most high-yield stuff. And this image here, right, kind of helps you understand, both of these images actually kind of help you understand what's happening in hemochromatosis. So mutation of the HFE gene leads to reduced iron uptake and causes enterocytes and hepatocytes to sense falsely low iron levels. Right, so your body thinks you have low iron levels. Enterocytes then express more DMT1 for intestinal iron absorption from the lumen, and the liver decreases hepcidin synthesis, thus increasing ferroportin expression on enterocytes to increase iron secretion into circulation, all of which leads to excessive iron. Right? So not only are you secreting iron into circulation because your body thinks you don't have enough, but you're also absorbing a lot more from the gut, thereby pretty much doubling how much iron you're supposed to normally have there. Right? Hepcidin is a very big regulator of iron. You want to make sure how that works, know how that works, and then the main player is ferroportin 1, DMT1. Right? Definitely want to make sure you understand how these guys work. Okay, so that's pretty much everything about hemochromatosis right there. Question number 4. This one was, a 32-year-old woman begins to hyperventilate and then develops blurred vision and numbness around her mouth after being told her best friend has suddenly died. Right, so she's panicking. Her pulse is 95 per minute and blood pressure is normal. Which of the following is most likely decreased in this woman? Right. So first thing was to understand that she's panicking, she's hyperventilating. Right. All of this is a normal thing that can happen after being told someone passed away. Now, what's going to be decreased? So this was a pretty difficult question for a couple people that I saw online. The correct answer here was D. Your cerebral blood flow will be decreased, and very few people were actually able to grasp that. This patient most likely had a panic attack after hearing the bad news. Hyperventilation decreases PaCO2, right, because you breathe out all your CO2. Central chemoreceptors respond to the low PaCO2 by vasoconstricting cerebral blood vessels, and that's a physiology you need to know. If you knew that physiology, you had it memorized, and you understand it, you would immediately pick D and just move on. Answer choice A says arterial blood oxygen concentration, but arterial blood oxygen concentration is directly related to hemoglobin concentration and hemoglobin saturation. Via the Haldane effect, decreased PaCO2 will increase oxygen saturation, thus increasing blood oxygen concentration. Right? Very important to understand the Haldane and whatever the Bohr, the Haldane and Bohr effects, because those guys are pretty much what help you bring CO2 out and bring oxygen to your tissues. So those effects are not exactly the most high yield thing, but they're pretty significant. It's a pretty big part of respiratory. Right? But arterial blood oxygen concentration would be increased. Arterial blood PO2, right, which pretty much sounds like the same thing as answer choice A. PaO2 changes in response to decreased arterial O2, inspired oxygen, or diffusion. There would be no change in PaO2 during hyperventilation, theoretically, so it would just stay the same, right? When you do respiratory, you get to learn how all of that works. I haven't done my newer respiratory videos yet, but my older respiratory videos do explain respiratory physiology in quite good depth, because respiratory physiology is actually pretty hard. A lot of people don't think it's hard because they didn't really understand it to begin with, but it's actually almost as difficult as cardiovascular physiology, minus the multiple heart sounds that you hear, because there's a bunch of graphs as well in respiratory. Answer choice C was arterial pressure, but arterial pressure, remember that if you decrease PaCO2, that causes vasoconstriction, that would increase blood pressure. Okay, and if you couldn't remember the vasoconstriction part, you wouldn't get this question right anyway. But the arterial pressure you could knock out still, because when you're given stressful news, your blood pressure usually goes up, right? That's like a common folk conversation, not a medical conversation, but if someone gives you very stressful news, your blood pressure will go up. And that's kind of how I memorized panic disorder and what happens with, cerebral blood vessels. When someone comes and tells you something very stressful, I need you to work overtime today, I need you to come in on Saturday, tomorrow, blah, blah, and stuff that really messes up your normal routine and gives you anxiety, that elevates your blood pressure, right? Stressful news elevates your blood pressure. Elevation of blood pressure is related to vasoconstriction, right? So that's something you want to maybe use to kind of memorize this physiology over here. The last thing, cerebral blood flow, that was the correct answer, sorry. Cerebral tissue pH. Cerebral tissue pH would increase due to respiratory alkalosis, right? And that's pretty obvious because they tell you she's hyperventilating. That means she's losing all her CO2, and CO2 is acidotic, so now things are going to become alkalotic, right? So interesting question. This is basically a question on, let me see, 312. The baroreceptor and the chemoreceptor stuff right here, right? And they tell you, right, the chemoreceptors are the other thing where we're doing the central stuff, right? Stimulated by changes in pH and PCO2 of the brain, interstitial fluid, blah, blah. There's some explanation I have here about the Cushing reflex, right? Triad of elevated blood pressure, which is vasoconstriction, bradycardia, and increased intracranial pressure with respiratory depression. Right? And this is another thing that you often get questions on. On the left is a UWorld question about that topic. We've already done this in cardiovascular, but if you're curious, you can always feel free to pause the video here and check out what's being discussed. But our patient was going through a sympathetic issue, right? Because she's just gotten some really scary news. So although it's not due to hypotension, that scary news is still causing more efferent sympathetic firing, vasoconstriction, increase in heart rate, increase in contractility, increase in blood pressure, right? Important in the response to severe hemorrhage, which is the hypotensive version, but the other version is the one where you just get really bad news, the panic disorder version. All right. So I'm going to add this into the list as panic disorder / baroreceptors. All right. So now, next topic. This this was pretty cool. This is a really easy thing. You want to make sure you get this because it's really not worth getting wrong. Let me make this bigger. I forgot to increase the size here. So UWorld had a question about it too, and I put the UWorld question here. And this is a question from NBME 18, and this is our NBME 22 question. So it says a 2-month-old boy is brought to the physician because of a 7-day history of hoarseness. His mother has AIDS and used cocaine throughout her pregnancy. Physical exam shows no abnormalities. A fiber optic laryngoscopic examination shows a nodule on the left vocal cord. Which of the following viruses is the most likely cause of this nodule? Okay. And the answer here was just human papillomavirus. It's definitely not CMV or HSV. HIV doesn't cause nodules. HIV doesn't really cause anything, actually. It just turns off your immune system. And varicella-zoster also doesn't cause this issue. So what this is about is human papillomavirus causing laryngeal papillomatosis. Right? Page 722 of my own PDF discusses HPV and the laryngeal papillomatosis. The above NBME or the below NBME 18 question and this UWorld question give more insight. So let's take a look. NBME 18 had a question about a 6-year-old girl being brought to the ED by her father because of a 15-minute history of severe shortness of breath. The father says that she was diagnosed with a throat tumor 3 years ago. Her respiratory rate is very high, 32, and physical exam shows nasal flaring. Laryngoscopy shows multiple raised finger-shaped lesions arising from the vocal cords and epiglottis and partially occluding the larynx. The lesions are excised. Microscopic exam of the lesions show finger-shaped fibrovascular cores lined with benign squamous epithelium. What is the most likely causal virus? And that was also HPV type 6. And the UWorld question, same kind of stuff. A small DNA virus is described and has affinity for stratified squamous epithelium. The virus is most likely to affect which of the following respiratory structures, and it affects the true vocal cords, right? Only 33% of people got that right. The other people were kind of all over the place, right? Of the answer choices listed, the true vocal cords are the only area covered with stratified squamous epithelium, so that's one thing you have to remember. The virus described could be HPV, which causes warty growth, papillomas, which are also described as finger-like, right, finger-shaped lesions, papillomas. on the true vocal cords, producing hoarseness and stridor, upper airway obstruction, right? So the combination of these questions really sums up everything you can pretty much get in presentation. So this is HPV laryngeal papillomatosis, right? And Vanessa's saying this is also on NBME 24. So that's kind of why I'm compiling this list, right? So on my third monitor here, I'm kind of putting together a list of everything that's going to be on this NBME, because these topics tend to just repeatedly appear on all NBMEs. So it's, if you're truly preparing just for NBME because your school requires it, it's very important to make sure you know what topics you need to know. Don't waste time studying things that you don't need to know. And that's actually pretty cool, right? Because if NBME is about 60% of what first aid has, it's great to master that 60% first, kick ass on NBME, then go and study the rest of the stuff that was non-NBME topics, right? The other 40% of first aid. Alright, so that's number 5. I don't know how comfortable I would feel if I had thousands of viewers. I'd be like pretty scared, to be honest, but that would be pretty awesome. Number 6. So a 16-year-old girl is brought to the physician because of excessive dieting, constant studying, and social withdrawal during the past 3 weeks. She's 5 feet 6 inches tall and weighs 106 pounds, so her BMI is pretty low. Her blood pressure is also low. Physical exam shows dry skin and fine hair growth. Right, and you have to remember this fine hair growth. I think this is the thing that was called lanugo. Lab studies show sodium, potassium is very low, chloride, bicarb higher than normal, right? Urea, nitrogen, creatinine is elevated. Blood gas analysis shows alkalosis, right? Okay. Patient has most likely been abusing which of the following substances? Well, her potassium being that low is kind of a giveaway for diuretics, right? All diuretics, generally speaking, all diuretics cause you to lose potassium except the potassium-sparing diuretics like spironolactone. So this was a really easy question in that aspect, right? This patient has a creatinine of 1.2 and very low potassium along with metabolic alkalosis. Loops lose calcium. However, that wasn't given. But loops also cause metabolic alkalosis and are the best at lowering potassium. Inhibition of the sodium-potassium dichloride channel causes a lot of potassium to be lost, as well as sodium and chloride, which is also evident. Her sodium is also low. And you can see all of that in the labs. Normal chloride is 96 to 106, hers 90. Her dry skin and fine hair growth are mechanisms that her body is administering to tackle the anorexia, right? Her low BMI, lanugo. You make more fine hair. Pretty much fine hair growth is like baby hair. So this young girl is making more baby hair to conserve heat, to stay warmer, right? So this was just diuretics. Diuretics make you lose a lot of potassium. Okay, so this is going to be a topic about, I guess, anorexia and diuretics. Okay. Alright, so not so bad at all. Next one, number 7. A 67-year-old woman comes to the physician because of a 1-year history of a non-productive cough and progressive shortness of breath with exertion. She has not had fever or any other symptoms. She has no history of serious illness and takes no medications. She does not smoke. Vital signs are within normal limits. Pulse oximetry on room air shows an oxygen saturation of 92%. Fine, dry crackles are heard at both lung bases. Physical exam shows clubbing of the hands. No peripheral edema. Chest x-ray shows fine linear opacities in the lower third of the lungs bilaterally. CT scan of the chest shows bibasilar interstitial reticulonodular markings with interlobular septal thickening. Septal thickening, that's a pretty big deal right there. That's actually very specific to what's wrong with her. Pulmonary function tests show a normal FEV1 and FVC of 48% of predicted. Diffusing capacity of lung for carbon monoxide is also low, which is actually going to help you figure out what's wrong as well. This is actually seen in only a select few cases. Which of the following is the most likely diagnosis? So you look at all your answer choices. Now, NBME very rarely gives you a big paragraph, right? That's not something NBME does. As you could tell, NBME is notorious for giving you pretty much just two-liners, right? They don't give you big paragraphs. So when they do give you big paragraphs, it's actually just to confuse you. This is actually much more easy than it seems because they gave so much extra information. But this is just a very old woman with bilateral lung issues, okay? And she has decreased DLCO, right, diffusion capacity of the lung for carbon monoxide. So her issue is just idiopathic pulmonary fibrosis, which is another pretty high yield topic on NBME. And let's talk about how you're supposed to figure that out. So the first clue is that it's a restrictive lung disease because of the information they gave you, right? The FVC is 48% of predicted, vital capacity is very low, so it's a restrictive lung disease. Next, the DLCO is decreased. Normal is 80 to 120%, but hers is very low, 55% of predicted, meaning there's an issue with the alveolar pulmonary capillary barrier, right? That's because that's where diffusion occurs. DLCO is only low in restrictive interstitial lung diseases and emphysema. Okay, and this patient, emphysema is an answer choice too, but this patient does not have emphysema. Emphysema is an obstructive lung disease, which presents differently. It would not have a normal FEV1. The CT that they're describing has classic findings for idiopathic pulmonary fibrosis, right? Where is it? The CT, physical exam, chest X-ray. Linear opacities in the lower third of the lungs, and then the CT right here, bibasilar interstitial reticulonodular markings with interlobular septal thickening. All the stuff in this line right here, chest X-ray and CT combined, that's how you're supposed to diagnose your answer, right? That's where you get your answer from. Not everything else they told you. That is where you get your answer from. In fact, the last 3 lines, pretty much all of this is where your answer comes from. Okay, so the clinical picture of non-productive cough, shortness of breath with insertion, no fever are consistent with idiopathic pulmonary fibrosis. Overall, this is a very non-ambiguous question. It was actually very specific. They made sure you didn't pick anything else because they gave you so much information that you either get confused and lost or you know exactly what's wrong. Okay, so you look at restricted lung diseases, you can see how all the interstitial lung diseases, right, under restrictive have a decreased diffusion capacity for carbon monoxide. This includes the pneumoconioses, the sarcoidosis, idiopathic pulmonary fibrosis, which is our patient, right? Goodpasture syndrome, because that is also antibodies against the same area of the lung. Wegener's granulomatosis with polyangiitis, pulmonary Langerhans cells histiocytosis, hypersensitivity pneumonitis, which looks like this, and drug toxicity. All of these are things where you have decreased DLCO, right? Our patient has the idiopathic pulmonary fibrosis, which is described in this manner. Okay, interstitial lung diseases lead to pulmonary fibrosis with thickening and stiffening of the pulmonary interstitium. This causes increased lung recoil as well as airway widening due to increased outward pulling, the radial traction, by surrounding fibrotic tissue. Right, you could see fibrosis in all of these guys. Even the hypersensitivity pneumonitis, that's kind of showing you fibrosis over here. Okay, the blue stuff. The resulting decrease in airflow resistance leads to higher than normal expiratory flow rates. All right, very easy stuff. Just, gotta make sure you know where you see specific kinds of labs. DLCO is normal. You can see right here is normal in asthma, right? And it's also normal in bronchitis. But emphysema might have low DLCO because there's, again, damage to the place where diffusion occurs, the alveoli, right? Also with idiopathic pulmonary fibrosis, keep in mind, what is the honeycomb thing, this one, right? You often get x-rays that look very much like this, CTs that look very much like this. They call it a honeycomb lung appearance, okay? You got to make sure you catch that, right? That's something that's very much specific to idiopathic pulmonary fibrosis. You don't necessarily see that anywhere else, all right? What is this one again? This is bronchiectasis, yeah. Okay. All right, so that's it for. Okay, well, we haven't done respiratory, but you see image B over here. This is often also mistaken by people for a honeycomb appearance, but this is not honeycomb. you can see everything is black, right? I know you see a bunch of lines, but everything is nice and black, which means it's full of air. In this one, it's got mostly gray because there's a lot of fibrosis. There's not much air in there. There isn't much space for diffusion of air either. It's just all fibrosis. And it's idiopathic. Usually occurs because of repeated lung injury. Right? They tell you right here. Repeated cycles of lung injury and healing. So very high yield topic. You want to make sure you understand it and the other stuff in the answer choices as well. Number 8, a 17-year-old boy is brought to the emergency department 45 minutes after he collapsed while competing in a high school wrestling competition. He's 5 feet 10 and normally weighs 135 pounds, but he competes in the 128-pound weight class. On arrival, he is alert. His pulse is 104 per minute, blood pressure is low, physical exam shows pallor and diaphoresis. I see sweating. After administration of IV fluids, he says he feels back to normal. On further questioning, he says that he was afraid that he would not qualify to compete in his weight class, so he took a long steam bath and used a laxative prior to the match to quickly lose about 5 pounds. Lab studies are most likely to show what? So the question is about what happens when you sweat too much and you take laxatives, right? Those are the two things you just did. The answer here was also hypokalemia. It's the same kind of thing that occurs when you abuse loop diuretics. This same patient, the same 17-year-old boy, could have, maybe 2-3 weeks ago, started using loop diuretics to quickly lose weight for the same competition. Right? So another way the question can present. A good fact to come into memory is that you lose bicarbonate in your stool, hence why diarrhea causes non-anion gap metabolic acidosis, and especially lose potassium with laxative abuse, as mentioned in the question stem. In addition, loss of fluid triggers aldosterone production, so the patient will have hypernatremia and hypokalemia, right? Because he was sweating excessively. He's very dehydrated. You know he's dehydrated because when they gave him IV fluids, he felt better. They didn't need to give him any medications. So looking at all the answer choices, like hyponatremia definitely didn't make sense. He would have aldosterone release. That's the physiology you want to make sure you understand anytime you get a patient with excessive sweating or dehydration, right? And aldosterone conserves sodium, throws out potassium. So you immediately just pick hypokalemia, even if you didn't know that laxatives do what they do in this explanation and whatnot, okay? Very easy topic, very realistic scenario. This is something that occurs in reality. Number 9, a 12-year-old girl is referred to the emergency department by her physician because she has been unable to walk for 5 days. Her parents appear very anxious, but she seems unconcerned about her symptoms. Her temperature, pulse, and blood pressure are all given to you, and your temperature is okay, pulse is also okay, blood pressure is also just fine. Deep tender reflexes in the lower extremities are equal bilaterally. Sensation of pain and light touch is variable, so that's not normal. Sensation of light pain and touch is not working fine. Which of the following is the most likely diagnosis? Okay, so this was actually a topic from psychiatry, and you could tell because when you look at your answer choices, those are all psych issues. So you look at your answer choices and you go back to the question again. But if you're reading questions and you're not reading it actively, you're going to forget, you're going to waste a lot of time rereading the question. So you should be reading actively the first time you go through it. And the first time we went through it, I said things, right? I said things, and those are the things you're supposed to say to yourself when you're reading a question. This is a little slightly off topic, but basically when you're reading questions on step 1, NBME, whatever study you're doing, don't just read the question. You're going to get sleepy, you're going to forget what you read, you're going to waste time. When you're reading a question, tell yourself what's happening. And I told myself everything's normal, but the sensation part, right? The sensation part's not normal. I don't even need to reread the question anymore. I got what I needed from there. And then I look at all my answer choices. This doesn't make sense for brief psychotic disorders. I didn't read anything psychotic in the question. Conversion disorder is immediately the correct answer if you remember what conversion disorder does. This was not depersonalization, derealization. She didn't remove herself from her body. This is not hypochondriasis, right? She's not a hypochondriac. And this is definitely not PTSD because they didn't even mention a S. They didn't mention a T. They didn't mention a trauma that she went through. But she has pure functional neurologic loss, right? This is conversion disorder. The patient will have loss of sensory and motor function after some acute stressor. This patient also has labile indifference, where she is indifferent toward her symptoms. She doesn't care. She doesn't feel like something's wrong, right? They tell you that. She seems unconcerned about her symptoms. So page 613, let's take a look at it real quick. Right, under your malingering, factitious disorder, and somatic symptom disorders, our thing was under somatic symptom disorders, conversion disorder. Right, her stress is converted to some sort of paralysis or neurological deficit, also known as functional neurologic symptom disorder, loss of sensory or motor function, often following an acute stressor. Patient may be aware of but indifferent towards symptoms, which is the labile indifference. More common in females, adolescents, and young adults. Right? Very straightforward topic. Her presentation in this question didn't fit anything else. Okay, brief psychotic disorder is a schizophrenic. Is schizophrenic positive symptoms lasting less than 1 month. Right? Depersonalization is a dissociative disorder of detachment from one's own body and thoughts. Hypochondriasis is when you're being a hypochondriac, which is basically someone that says, "Yo, I'm definitely sick. I'm definitely sick," right? Even though they have no symptoms, right? That's what a hypochondriac is. This is something you want to start using in normal language, so you get used to the terminology and the physiology, and you understand what it means. So if you have a friend who's always telling you, "Oh my God, I'm definitely going to be sick tomorrow," or "I'm definitely going to be sick," or "I am sick," you can call that friend a hypochondriac just for purposes of memorizing what that word means. And PTSD makes life hard, right? Hyperarousal, avoidance, and re-experience, and distress. I mean, we didn't have any of that as well. And they didn't really give you any stressor either, but that's okay. You didn't need it, right? They didn't tell you what acute stressor might have caused the conversion disorder. UWorld, on the other hand, would probably tell you some kind of acute distressor this girl went through, but it wasn't necessary, right? NBME gives you exactly what's necessary, which is everything's fine except that she has some sensation issues. Okay, so this is conversion disorder number 9. All right, number 10. So this one says an 85-year-old woman is diagnosed with a fracture of the right femur and begins treatment with morphine by patient-controlled analgesic pump. 3 days later, she has respiratory depression, right, because it's 6 per minute. Physical exam shows pinpoint pupils because she's completely relaxed from the overdose of opioids. Her serum creatinine is 1.8 because I'm sure the excess opioids is causing renal injury. Which of the following best explains this patient's clinical deterioration after the initiation of morphine therapy? So you look at all your answer choices, right? Now you got to be very clever with your answer choices because you can tell they're not 2 to 3 word answer choices. But you see how I read the question again? Always do that. Don't just read the question. Read it the way I did. Say things to yourself. Comprehend the patient, understand the scenario, and predict what's happening. So A, chronic dosing of morphine decreases its bioavailability. This is not true. Chronic dosing does not affect bioavailability. In fact, almost nothing affects bioavailability of any medication. It's an intrinsic property. Morphine bioavailability increases with chronic dosing. Again, if A is wrong, B is wrong. That's, because of the same logic. Bioavailability does not get affected by dosing. C, morphine downregulates mu opioid receptors with chronic dosing. Ooh, right. This is a nice trick answer choice here because what they're saying logically makes some sense, but it's not true. What they're trying to tell you here is that, if you keep taking opioids obviously work with the mu opioid receptor. So will your body stop showing mu opioid receptors because you have so much morphine activity? That's not true. Think about it. Anyone that takes morphine continues taking morphine because it works every time you take it, right? Which means that you're not becoming tolerant to it, right? That's what this answer choice is describing. Answer choice C is describing tolerance, and that's not something that happens with opioids, generally speaking. D says morphine inhibits its own metabolism, and that's just bullshit, right? Like, where the fuck did they get that from? That doesn't make any sense. E is the only answer choice left. If you're running out of time, you just lock it in and move on, especially if you already canceled everything correctly in your mind. Like, you were very clear about it. But if you have time, you read it. Morphine is metabolized to active metabolites that accumulate, which, doesn't seem like bullshit, doesn't seem like completely unrealistic stuff. And it also makes sense that the active metabolites must be what also caused the renal injury. Right? So that was the answer here. E. Morphine is metabolized in the liver to morphine 6-glucuronide and morphine 3-glucuronide, both of which are excreted by the kidneys. In the setting of renal failure, these metabolites can accumulate, resulting in a lowering of the seizure threshold. And she's 85. Remember, don't ever forget the age when you read it in a question. So her kidney is definitely not working the way it used to work 80 years ago. Source, so this link right here kind of tells you a little more about these metabolites in case you are interested. They gave a hint of an increased creatinine level plus older age can give a slowed down metabolism and CNS symptoms. A and B make no sense. Opioids do not downregulate mu receptors, but if they did, then few receptors would mean lesser effect because of tolerance. This patient has effects of an overdose, and D is false. Okay, very easy topic. But a lot of people got very confused because of the way the answer choices were worded. And the reason NBME is so awesome is because this kind of stuff, if it intimidates you, that's how you know you're not ready, right? And then you practice it more, you get better at it, you understand the technicalities about availability and dosing and how all of that works, how opioids work, which obviously is an extremely high-yield topic, not just for exams, but your real practice, because it's a really big epidemic right now where people are dying because of opioid abuse and nothing can really be done. And then, you keep practicing until you get very confident at it, at just tackling answer choices, like the way I just broke it down for you guys. All right. Number 11, this is an ethics question. So it says, a 50-year-old man who is a college professor has had an increasing cough for 6 months and hemoptysis for 1 week. He has smoked 1 pack of cigarettes per day for the past 32 years. He plays squash twice a week and swims 3 times a week. X-ray of the chest shows a hilar mass. Cytologic exams of sputum shows non-small cell carcinoma. So he evidently has lung cancer. The physician tells the patient he has lung cancer. The patient responds, "How can this be happening to me? I eat right and I exercise. Which of the following responses by the physician is most appropriate?" Now, the inappropriate response would be, "Yeah, man, you exercise, you eat right, but you also fucking smoke, right? You smoke." And that's inappropriate because I can't talk to him like that, right? But the truth of the matter is that he's kind of only looking at the good things he does and not looking at the bad things he does. So now, you have to pick an answer choice in ethics. Always make sure that the answer choice you pick is the most wimpy, sensitive answer choice as possible, right? You want to assume that your patient is like a 3-year-old that will get mad when you tell them they can't have candy, something like that, right? Never say something that can be even remotely intimidating, condescending, offensive, any of that, right? If you can make your patient feel bad, it's the wrong answer choice. So let's look at them. A, don't worry, I will be there for you and make sure everything turns out the way you want. A is just wrong because that's lying. That's you don't lie to your patient, right? B, eating right and exercising will not help prevent cancer. Well, again, that's mean, right? I'm just denying what he just said. He said, I eat right and I exercise. How can I get cancer? And I'm here sitting there, well, listen, my dude, you eat right and exercise, but that doesn't mean you're not going to get cancer. Eating right and exercising is not a vaccination against cancer. That's just me being mean. I can't say that. C, in fact, as you probably know, the major risk for lung cancer is smoking. That's the inappropriate thing I wanted to say, right? Yeah, dude, like, I know you eat right and exercise, but you also smoke. Let's not act like you don't smoke. Again, C would also be very mean. A lot of people were very inclined on picking C, right? Because as a doctor, you always want to be mean to patients because of the things they do, right? You get patients who have diabetes and renal injury, yet they go on eating binge sugar stuff, right? Cake and whatnot. Come into the clinic holding a Gatorade bottle full of sugar, right? Things like that will often piss you off as a doctor, but you can't exercise that anger, right? Carrying yourself as like a doctor is something that's a very real thing. Anger cannot really be a part of your character, right? It's very non-charismatic. It's very offensive. As choice D says, it must be difficult for you to accept this diagnosis when you feel healthy. as an initial response, this is very sympathetic, right? I'm sympathizing with him because the only reason he said this, how can this be happening to me, is because he's freaking out. Okay? And E, regardless of your good habits, it's time to realize you have lung cancer. That's just fucked up. That's super mean also. Okay? So D was the best, wimpy, most sensitive, most sympathizing answer choice you could possibly pick. And that's kind of what you want to make sure you do. I feel like that's like the algorithm for figuring out how to pick an ethics answer choice. Because I know a lot of people definitely struggle with ethics answer choices. Just pick the most wimpy answer choice. Something that will never, not even remotely, make your patient feel bad. And don't lie, obviously. Don't ever lie. So A was wrong for that. Alright, so that was 11, 12. Okay, this was a really cool one. So this one I'm going to need to take some time on because math is a very integral part of step 1, right? You probably haven't done math in a very long time, ever since maybe even college, because most of us were science majors in college, right? But I was actually a math major in college. I just really liked math because I guess that's the Indian in me. And excuse me. Okay. And it's very, it's very nice if you have a good understanding of just basic math. You don't need to know calculus and differential equations and, upper level math and stuff like that. If you do know it, it definitely helps. If you understand the concept of a derivative, that helps too. But generally speaking, you want to be able to do basic math. How to graph things, how to read a graph. Those are two things that are very critical for step 1. Here is a very good example of how that's critical. So this tells you a screening test for cancer is developed and applied to 500 subjects known to have cancer and 500 patients without cancer. Using various cutoff points for the test, A, B, C, D, and E, the sensitivity and specificity of each cutoff point are plotted on a graph of sensitivity as a function of 1 minus specificity. Right, so they used very mathematical terminology here. They're telling you that they graphed sensitivity as a function of 1 minus specificity. That just tells you the axes, right? So your x-axis is going to be 1 minus specificity, y is your sensitivity, okay? Which of the following cutoff points will most effectively rule in cancer, right? Now, cutoff points, ruling in and ruling out, these are pretty difficult things for a lot of STEP students, medical students in general. But this was actually a very easy question. First things first, right? How do you rule something in? So you remember your spin mnemonic, right? So let's actually read what I wrote and then I'll talk more about it if necessary. So here the answer was just A. This one right here. That would be the cutoff point. That would be the cutoff point that would effectively rule in cancer almost always. Everyone is going to have cancer now. Very easy. A is the point with the lowest sensitivity and the highest specificity. As specificity increases, 1 minus specificity decreases or goes closer to 0, right? Basically, you want your specificity to be really, really high. So if you want that to occur, you're basically going to make specificity 1, 100%, right? And 1 minus 1 is 0. That's going to be the closest to 0, right? What we're basically saying is that specificity should equal 1, which is basically 100%. And if that happens, the 1 minus specificity is basically 1 minus 1, which is 0, right? And the point that's closest to 0 is A. Okay, that's kind of what you're aiming for. Right, that's kind of exactly what we want from this graph. Sensitivity is your y-axis, right, the height. And the higher you go, the more sensitive, which means you can rule out cancer. So A is the least sensitive, right? You can gauge each point based off of how high it goes and also how far to the right it went, right? And A was the best answer choice because A does not go high at all. It's the lowest point, and it also doesn't go to the right at all, right? Because remember, this is not just specificity. If your y-axis just said specificity on it, that would be a different scenario, right? Then you would want it to go further to the right, because you want 100% specificity, okay? But this is 1 minus specificity, which generally just means the other way around. Now, specificity is spin, right? Spin means specificity rules things in. Specific tests, my bad, rules in Cancer. Right, specific tests rule in Cancer. And if your specificity is 1, then 1 minus specificity will be 0, which is the 0 point of the x-axis. Okay, very easy stuff. You didn't really need to freak out too much. But again, another reason NBME is awesome. It makes you freak out, right? And when you freak out about any topic, it's a giveaway to you that you're not that good at it, right? Then you go ahead and accept it, and then you go ahead and master it, right? At the bottom, I also put some of these extra things that we've talked about in my lectures when we did biostatistics. Always remember that sensitivity is your true positive rate, which is 1 minus your false negative rate. So the false negative rate is 1 minus sensitivity. Okay? Snout. The N reminds you it's a false negative rate. Sensitive tests help you rule out disease. Specificity is your true negative rate, which is 1 minus false positive rate. Thus, your false positive rate is 1 minus specificity, which is what they gave us. Spin. The P reminds you it's a false positive rate. Okay, false positive rate is 1 minus specificity. Very easy stuff. Just got to spend some time mastering it. Make sure you get how to do this, because it's very likely you get this question on your next NBME or on your step 1 even. Alright, so this is about statistics. Let's take a look real quick in first aid. I just want to see if I wrote that here too. I think I put that here too. Did I add that question in? Yeah, I think so, right here somewhere. No, I didn't. Yeah, I definitely want to put that question into here because it's really nice. Alright, but the other thing was that this question that we just did was kind of talking about this graph, right? Cutoff values for ruling in and ruling out stuff. I've already talked about this in my biostatistics video, and you can definitely feel free to pause it here and take a look at what's happening if you want, because I drew out more images to make it clear how this graph changes based off of what you do, whether you lower the cutoff point or raise the cutoff point. Okay, so B going to A, that's the left image here, that's you lowering the cutoff point, right? So if you lower the cutoff point, right, remember lowering is bad, it's very negative, increases negative predictive value and sensitivity. Right, snout, you rule out disease. Disease absent. You see how everything is blue. Raising the cutoff point, raises are a good thing, like when you get more money, and that's very positive. So you increase PPV and specificity. And this is just a memorization tool right here. Excellent memorization tool because it just works. It's really logical. You'll remember it. If you ever get a question about what will happen if I raise the cutoff point, you'll think about it. Raises are a great thing, very positive. PPV and specificity both increase. Okay. So memorization mnemonics are like pretty much what medical students live off of, where as far as step 1 is concerned, and you want to make sure you use this the best you can. Let me just make a quick note here. Okay, all right. So I'm going to put this question into the book too because I really like the way they worded it, and this needs to be in the book as well. So I'll put that in. Now we're on number 13, so that's pretty much half of what we're going to be doing today. This video is an hour long already, so what I'm going to do right now is I'm going to take a little break, go get something to eat. I'll come back and we'll... No, do I want to take... No. I usually do 25 questions without stopping. No, it's okay. I'm alright right now. We'll keep going. Let's see. 49-year-old man has had the gradual onset of numbness and pain of the left index finger over the past 3 weeks. Pulses are full and equal bilaterally. The left index finger is mottled blue and pale. Lab studies show all of this. So hemoglobin looks okay. Hematocrit is fine. All of this looks... Oh, platelet count is super high. Look at that. All right, so platelet count is over 1 million per millimeters cubed. Examination of bone marrow shows normal cellularity, normal iron stores, and megakaryocytic hyperplasia. So it looks like he's still making more platelets too. Which of the following is the most likely diagnosis? So this guy is just making a lot of platelets. That's all it is. So it's just B, essential thrombocythemia. That's it. This is not CML. This is not myeloid metaplasia, nor is it polycythemia vera. Then he would have really high hemoglobin. Nor is this reactive thrombocytosis. Reactive thrombocytosis would be you making platelets because you need it, in which case you would also use the platelets up. They wouldn't accumulate. Okay, so this was B. Take a look at that massive platelet count, over 1 million per millimeter cube. That should point you towards a myeloproliferative disorder of some sort, since this fella isn't bleeding out as far as we can tell from the blood panel, which would basically put reactive thrombocytosis on the diagnosis, but that's not correct. Now let's look at the erythrocytes. Everything's normal, so it's not polycythemia vera, right? And his leukocytosis and all of the other stuff is also normal, so it's not CML or myeloid metaplasia, so it's just going to be essential thrombocythemia, which is one of your chronic myeloproliferative disorders. Right, very rare question actually. I've never really seen someone get a question on that before. Right, massive proliferation of megakaryocytes and platelets is just essential thrombocythemia, which is a chronic myeloproliferative disorder. Very rare question. I wouldn't say it's high yield, and I don't think I've seen it in many other NBMEs either. But it's a very easy question, right? Because it was very evident what was wrong with the patient. You look at the labs and you immediately see it. His platelet count was just way too high. This one was also actually pretty nice, not that bad at all. A study is conducted to assess the extent of cardiac valvular abnormalities in patients receiving ergot dopamine agonists. Group X consists of 40 patients who have been treated with an ergot dopamine agonist for at least 1 year. Group Y consists of 54 age and gender matched controls. It is found that patients in Group X have significantly greater composite regurgitation scores than Group Y. The investigators decide to double the number of patients in each group and keep the same criterion for statistical significance. This change will most likely have which of the following effects on probability of type 1 and type 2 error? Okay. So, they tell you they're going to double the number of patients. That's basically going to increase sample size. And then you have to remember what type 1 and type 2 error are about. Remember, type 1 error is an alpha 1. That's the one that accuses an innocent man, which is a false positive, right? An alpha error. Type 2 is beta, which blindly releases a criminal. That's a false negative, a beta error. Type 2 is related to statistical power, which equals 1 minus beta, where power is increased by increasing sample size, right? So if you increase power, you decrease beta. So basically, you needed to remember that type 1 error would not be increased. So you're immediately only between acid choices D, E, and F. You knock out everything else. You're between D, E, and F, and you know that if you're increasing sample size, that's a good thing. You're going to decrease type 2 error, right? So it's just F. Very easy question, actually. But if you didn't remember any of that at all, then it became a very difficult question, which is why I always tell people, you got to make sure you know your biostatistics and ethics stuff very well, because, it's not like knowing cardiovascular. Like, you can know cardiovascular extremely well if you want, but you can still get questions on cardiovascular that are going to be very hard for you. You can know this very well, and you're never going to get a question that's too hard because you'll just know it, right? So that's the little difference between the two. So you don't want to brush over biostatistics and stuff like that, the mathematical things, pharmacokinetics, pharmacology. Those are things you maybe want to spend time on the month before your step 1, because now you're done looking at everything already, and you want to make sure you have good memorization mnemonics. This one, number 15, a previously healthy 26-year-old woman comes to the physician because of a 2-week history of fever, chills, malaise, rash, diarrhea, headache, and sore throat. Right, what a constellation of symptoms. 2-week history. Physical exam shows erythematous throat, diffuse swelling of the lymph nodes, and an erythematous maculopapular rash over the trunk and extremities. Lab studies show a leukocyte count of 10,000, CD4 count of 700, and HIV viral load greater than 1 million. So she has HIV. Results of serum HIV antibody tests are negative. Which of the following best explains this condition? Yeah, just A. This is very obvious. So a lot of people were actually inclined to pick HIV too, and I saw it. I haven't seen this URL question. I don't have it. If you've seen this URL question and you think you could show it to me, feel free to email it to me. But this was acute retroviral infection, and acute HIV-1 infection has a high viral load and high CD4 and CD8 T cells, but low HIV antibodies because you haven't yet started making that many of it. UWorld had some HIV-2 question that taught HIV-2 infection has a low viral load and low antibodies, since the standard HIV assay detects P24, which is not present in HIV-2. Right, so a lot of people were confused about that and wanted to pick HIV-2, but that doesn't make sense. Our patient does not have a low viral load. Their viral load is actually pretty high, right? This patient basically recently got HIV and is now in the flu-like phase of acute viral infection. So let's take a look at that graph. There's a very nice graph that kind of depicts how HIV develops, the time course of untreated HIV infection. In the beginning, the first 3 months, right, before the break is happening here, and the first 3 months, you can see the blue line, right, which is your HIV RNA, is very high. Right, this is acute HIV viral dissemination, seeding of lymphoid organs. It's very high. Your CD4 count is slowly going down, but it's still above 500. Above 500, hasn't gone to the part where you start getting a lot of really bad infections. And your antibody count is only increasing, but it hasn't really gotten too high. Right? You haven't really started making that many antibodies yet. Right? And then later on, right? Remember, CD8 doesn't get affected for a very long time. Once you have systemic immunodeficiency and AIDS-defining illnesses, that's when you know your CD8 count has gone to shit. But CD4 starts declining very early during the clinical latency period. Eventually, it becomes so low that the latency is no longer latency, as actual infection. Okay, so very important to make sure you understand how HIV infection progresses, because that's definitely a very high yield topic, and HIV in general is pretty high yield on NBME. They like asking you questions about the HIV medications as well. This one, number 16, a 50-year-old man is admitted to the hospital because of severe chest pain for 30 minutes. An ECG shows ST segment elevation in the anterior chest leads. Serum studies show increased CK and troponin and iron concentration, which means he definitely just had an MI. Compared with electrolyte content of normal myocardiocytes found in a healthy asymptomatic 50-year-old man, which of the following best reflects the electrolyte content of the myocardiocytes that produce the increased enzymes in this patient? Okay. So this is a pretty high yield topic. This question shows up all the time. UWorld had a very nice question about it too. Basically, when you get cell death, the first thing you always want to remember is that your sodium potassium ATPase is no longer working. Right? Your sodium potassium ATPase is no longer working. Remember that the job of sodium potassium ATPase is to pump K in. Right? Remember the pump K in mnemonic, and there's 2 P's in pump. So that means you pump 2 potassiums in and pump 3 sodiums out. Now you cannot pump sodium out. Sodium will be high inside the myocardiocite, causing cells to swell. Right? So if sodium is going to be high, you're immediately between D, E, or F. Potassium is going to be low inside the cell. It's going to be high outside the cell. Right? So now you're between D or E. Last thing is about intracellular calcium. How much calcium is there going to be inside this myocardiocyte? A lot, because your sarcoplasmic calcium ATPases also fail. So now calcium leaks out of the sarcoplasm and will be high inside the cell, contributing to hypercontraction, something that you read about in first aid, where they talk about progression of an MI. UWorld had a similar question. They tell you in experiments, transient MI causes myocardial cells to increase in size, swell. This effect is due in part to which of the following? And the answer choices were high. What's causing the cell to increase in size? Intracellular potassium, intracellular calcium, high cellular bicarbonate, cascade protein phosphorylation, or net cellular solute loss. And 21% of people chose potassium, but intracellular potassium is going to be low. Potassium is going to be stuck outside. The real answer here was calcium. 54% of people got it correct. Right? Without ATP, the sodium potassium ATPase stops working, and the sarcoplasmic reticular calcium ATPases also fail, leading to more sodium and calcium inside the cells, right? And potassium outside the cell. Okay, so that's something you just have to know. Make sure you remember that, and more importantly, make sure you understand that. Right, so that's number 16. 17 says, okay, yeah, this was pretty new stuff. Never really seen something about this before. So 43-year-old man is brought to the emergency department 1 hour after forcible eversion of his left foot while jogging on uneven ground. Walking is limited by pain. He rates the pain as 7 on a 10-point scale. His vital signs are within normal limits. Physical exam shows tenderness and swelling over the lateral malleolus. An X-ray of the left lower extremity shows a fracture of the fibula above the distal tibiofibular articulation. Contraction of which of the following muscles most likely caused this patient's pain at the fracture? NBME kind of likes anatomy. They act like you just came out of med school, and they kind of make it seem like you were just taking anatomy like 2 months ago. So you do kind of have to know all your muscles and compartments and where things are, on top of the other stuff that you probably already know, like what nerve supplies each area. Here the answer was B, your fibularis or peroneus brevis muscle. Now, how would you get that? Well, for one thing, you probably wouldn't get that. You would most likely get this question wrong, and you would just suck it up because why would you know this? But the truth of the matter is, it's pretty knowable. If you're studying this NBME, you'll know it now. But basically, our guy, you can see this muscle right here. Right, you have your fibularis longus and your fibularis tertius, right, which are also answer choices, longus and tertius. The correct answer was B, this one, your fibularis brevis, which is the one that connects like this. Right? This is the same connection the other one is having too, the fibularis longus, same kind of connection. But that one was wrong. So why? The fibularis longus and brevis are the only lateral leg muscles, and brevis is the only choice here. Right? They didn't have, they don't have fibularis longus, right? It's extensor digitorum longus. But these two are the only answer choices. Your fibularis longus and the fibularis brevis. Those are the only two muscles that connect in the way they do. Right? And both of them are lateral leg muscles. And that's what you needed to know. What are your lateral leg muscles? They are the fibularis longus and brevis. That's it. If you remember that, then you get this answer choice. Because you look at your answer choices, you only see one of them, and that's fibularis brevis, and that's it. Both are supplied by the superficial fibular nerve. The fibularis tertius is an anterior leg muscle, which are all supplied by the deep fibular nerve. Right? And you can see the tertius is a little more anterior, but I would say this is a pretty unfair question. The only people that would ever get this question correct is if you remember that the fibularis longus and brevis are the only lateral leg muscles. Now, in my PDF, I have Netter's anatomy notes, right, which kind of helps a lot, because if you did study from the Netter's anatomy note, you have every compartment listed out nicely with the innervation, as well as images that I took from teachmeanatomy.com, right? Combine everything together and you get a really nice study tool. Here is where I got the question correct from, right? So I did remember it. Remember when I'm doing these NBME explanations, one of the reasons it takes me so long is because I actually do the NBME. So I put my own answer choices first, and then I come back and check them, right? So I put B, right? I come back and check them, and I make sure that I got it right. If I didn't get it right, I also make a note of that. So far, I didn't get any of these wrong, but when I do get it wrong, I write it that I got this question wrong. This is what I thought the answer was. Right here, I remembered. I remembered because of this table, right? Lateral compartment leg, fibularis longus and brevis. Fibula, remember your fibula is on that side too, right? And then this image here is showing me how they go. You see how they both go the same kind of way, right? Those are the two muscles that were in our question, and they only had one answer choice, which was the brevis. They didn't have the longus. The other muscles, your fibularis tertius, you can see here is an anterior guy. Okay, and it's not even in this image per se, but it is over here, is it? No, then it's not over here either. But it's kind of probably a little harder to see because it's a little deeper, but it's on the table at least. So I didn't remember fibularis tertius, but it's okay because I remember these two, right? So having these tables and images in the same area, color-coded images from Teach Me Anatomy and these tables from Netter's Anatomy are very critical in a good final revision of anatomy, especially before your step 1. So 17 was anatomy of lateral leg. Right, 18. Let's go. Okay, so this was, this wasn't so bad. It's a 28-year-old man who is seropositive for HIV, has numerous non-ulcerated purple nodules on the skin. Examination of tissue obtained on biopsy of a lesion is most likely to show which of the following. So HIV and non-ulcerated purple lesions is a giveaway for Kaposi sarcoma. This patient has HIV, and Kaposi sarcoma is an endothelial malignancy related to HHV8. This would have a lymphocytic infiltrate since it is viral, as opposed to bacillary angiomatosis, which is bacterial, so that has neutrophils, right? And in this question, the correct answer was a little harder to pick because of the way it was worded. Right? The correct answer was F, slit-like vascular spaces with plump spindle-shaped stromal cells. Spindle cells are a weird thing, and online I found a list of places where you find spindle cells, so I put that here. And there's a bunch of them, and Kaposi sarcoma is one of the things that you can see spindle cells in. But the other way to get this right was to just knock out everything else. You're not going to see atypical lymphocytes, right? S choice A is wrong because atypical lymphocytes are seen with Epstein-Barr virus. Right? Granulation tissue containing pseudohyphae and budding yeast. This is not a yeast thing. So you can knock out B and C because this is not a yeast thing. Macrophages containing acid-fast bacilli. That is not what our patient has. Acid-fast bacilli like pneumonia, mycoplasma, that's not what we're talking about either. E, multinuclear cells containing intranuclear inclusions. Intranuclear inclusions are again like Epstein-Barr, cytomegalovirus, stuff like that. That's not what's happening here. Right? So even if you didn't know what F is about, you can knock out all the other answer choices. And you can easily knock out B and C, knock out A, then knock out D. These are all actually pretty easy to knock out. The only other answer choice that you might not be able to knock out is possibly E. That's it. Okay, so very easy question right here too. But again, remember, easy just means that you remembered it. You knew it, you studied it. There's nothing else. It's always going to be easy if you did study it and you do know the topic. 19 says, a 73-year-old man comes to the physician with his wife because of a 3-year history of daytime sleepiness. His wife says that he snores loudly. He is 6 feet tall and weighs 250 pounds with a BMI of 34, which is pretty obese. His pulse is 84 per minute, respirations are 18, blood pressure is 175, so blood pressure is very high, so it does seem like he has apnea, right? Physical exam shows congested conjunctiva and centripetal obesity. Serum studies show a glucose concentration of 250, which is really high, creatinine of 2, which means a lot of renal injury, and uric acid of 10. Polysomnography. Somnography, insomnia. Som means sloping, so they're sleeping, so they're doing a sleep study. So polysomnography confirms the diagnosis, and treatment with nasal continuous positive airway pressure at night is started. This therapy will most likely cause a decrease in which of the following? And then you look at answer choice A, blood pressure, and that's immediately the answer. This patient has obstructive sleep apnea. He's obese, he has diabetes, he has renal injury. All of this is happening because he has obstructive sleep apnea, which is also causing him to have very high blood pressure. The CPAP that they gave him, continuous positive airway pressure, that's going to fix his sleep apnea. The nocturnal hypoxia, right, because he's not breathing correctly all night. Imagine breathing like snoring all day, right? It's very uncomfortable. But overnight, you aren't able to really realize how uncomfortable it was because you're asleep. If you tried regularly breathing as if you're snoring all day long and do that throughout your day, you're going to feel very tired, right? You're going to feel like you're hypoxic, and that's exactly what happens in obstructive sleep apnea. You barely breathe all night while you were sleeping. That nocturnal hypoxia causes hypertension and can potentially lead to AFib and sudden death. The hypoxia also causes erythropoiesis. Stimulation of the hypoglossal nerve to move the tongue forward can also help fix this, and that was something that they taught in a UWorld question. Right, but sleep apnea is a very high yield topic. It's a very realistic problem. You will get a lot of patients that come in with that issue, and you need to know how all the different breathing patterns look. Okay. So obstructive sleep apnea, that's what our patient had. Weight loss, CPAP, and surgery are the only real answer choices in first aid. Stimulation of the hypoglossal nerve is another one that UWorld taught. Okay, so you want to make sure you understand these breathing patterns, right? These are very important. Also understand how different questions present. So if you didn't do this lecture with me, you can feel free to pause the video right here and check this out later on after I post it. And you'll get a good understanding of how to really differentiate between different types of sleep apneas and what these airflow graphs are all about. Okay, so 19 was sleep apnea. Okay, number 20. So I'm going to stop at 20 because the video is actually getting pretty long. And then after this question, we'll continue later on and do another 20 or 25, whatever I can do, and we'll keep going until we're done with all of it. So this is number 20. A graph is given, so you know immediately there's going to be a genetics question. And if you're not confident with genetics questions, that's another thing you really want to work on. Download a bunch of genetics questions and solve them all and start really seeing the pattern of how to do them. This is actually really easy stuff, but it's very easy to fuck it up too. 30-year-old man and a 24-year-old woman, indicated by the arrows, request preconceptional counseling because the man's brother has type 1 oculocutaneous albinism, which is an autosomal recessive single gene disorder thought to occur about once in every 40,000 persons in the general population. So they gave you the general population occurrence rate. Assume that the alleles are in equilibrium in the population, that the woman's family history is negative for this disorder, and that the two probands have neither shared relatives nor common ethnicity, which basically sets up the scenario for a Hardy-Weinberg equilibrium. Okay? A pedigree is shown, which of the following is the best estimate that their child will be affected with oculocutaneous albinism. Okay, so the man's family has oculocutaneous albinism. The woman's family has no history of it whatsoever. So how do you do this? First thing, calculations for the dad. The probability of the father being a carrier is 2/3, since it is known that he doesn't have the disease. And that was the hardest part, right? Once you get that part down, everything else is easy. Why was that the hardest part? Everyone tends to forget the 2/3 rule for autosomal recessive. Right? Remember that in autosomal recessive, right, with two carrier parents, on average, 1/4 of the children will be affected, this guy. Half of the children will be carriers, these two, and 1/4 of the children will be neither affected nor carriers, which is this guy. So the unaffected individual with affected siblings has a 2/3 probability of being a carrier. Right? So basically all three of these guys are unaffected, right? And if you don't know which one of these three you are, there's a 2/3 chance you're a carrier, right? If you have a sibling with the disease, but you don't have the disease, there's a 2 out of 3 chance that you're either one of these guys or you're this. 1/3 chance that you're this, right? This is a 1/3 chance that you're completely clear of the disease. You're not even a carrier. 2/3 chance that you're a carrier. Okay, so this rule of 2/3 is very critical. That's what sets up the entire math, and that's where you get the 1 in 600 from. In fact, before even locking in this answer choice and doing all the math, I predicted in my mind that I think the answer might be 1 in 600 because the 6 was the only way to get the 3 to work. Right? If you have a 3 in your math, you're going to get some multiple of 3 in your answer choice as well. But then I did the math. So calculations for dad. Probability of the father being a carrier is 2/3 because it is known that he doesn't have the disease, right? He's an unaffected individual with an affected sibling. Then the probability of him passing it on to his kid is always a half. Either he'll pass the good allele or the carrier. So the probability of dad being carrier is 2/3. Probability of passing the allele is half. Great. Calculations for mom. With the Hardy-Weinberg principle, you can figure out the probability of the mother being a carrier. Q is the square root of the general population, which they gave you is 1/40,000, right? So 1/40,000 is Q squared. That means Q is 1/200. Now 2PQ, remember if Q is 1/200, then P must be 199/200 because P plus Q equals 1. Right? So you find both of those things out. So I can put that here too. And thus P equals 199/200. Right? That's something you can deduce once you figure out Q. So that means 2PQ is 2 times P times Q, which is approximately 1/100. How do I get that? Basically, you estimate the 199/200. Excuse me. To just be 1. Okay, so instead of writing 199/200, you could just put 1 for calculation purposes. So 2 times 1/200 is 1/100. Right? That's 2PQ, which is what we need for our question. For the child to get the allele from mom, 2 things need to happen. Mom must be a carrier, and mom must pass the allele to the child. Probability of the mom being a carrier is the 2PQ, which is 1/100. Probability of the mom passing the allele is again a half. Right? So these are the things we needed. Probability of the dad being a carrier, probability of mom being a carrier, probability of each one of them passing those alleles, right? Very obvious, right? That's how you get the disease into the newborn. Putting it all together, you just combine it, right? So you're going to take the probability of the dad being a carrier, probability of dad passing the allele, probability of mom being a carrier, probability of mom passing the allele, multiply all that together, you get 1 in 600. You see why I could predict there would be a 6 in the answer choice? Because the 2/3 had to go somewhere, right? That was the only answer choice. These other answer choices could not really fit a 2/3 in the math. So if I had no time, 10 seconds left, I just got to this question, I would put D and move on. And I would get it right because the intuition would be correct from the autosomal recessive aspect of the disease. Gotta remember the 2/3, okay? So I take my time with these explanations, which is why this came down to the maximum 1.5 hours. I'm going to stop right here, question number 20, and then in the next video we'll keep going and we'll do as many more as we can. But every NBME explanation video is about 1.5 hours. I don't do more than that. So thank you very much for joining. Best of luck. Keep studying. Make sure you grasp all these concepts very well, and I'll see you guys again very soon.